Hello and welcome to our TIF Talk tonight. My name is Andrea Millers and I'm with Endogastric Solutions. I'm very excited to introduce two of our special guests this evening. We have Dr. Joshua Taylor and his patient, Todd. So welcome to the both of you and thank you for being here.
Thank you.
Oh, thank you.
Thank you. So, a little background on Dr. Taylor. Dr. Joshua Taylor is a general surgeon specializing in advanced laparoscopic and robotic surgery at the Surgical Clinic of Rutherford in Smyrna, Tennessee. He obtained his medical degree from Johns Hopkins University and completed his general surgery residency at Vanderbilt University. Dr. Taylor is a board certified by the American Board of Surgery and is a fellow of the American College of Surgeons. And Todd is Dr. Taylor's patient, as I mentioned, and he actually lives in Alabama. So, welcome again, and thank you for joining us this evening.
Thank
Thank
you.
you.
Fantastic. Well, for those of you that have joined us, thank you for joining us. As you all know, this is a live event. So at any time, if you have any questions, please feel free to ask your questions in the comment section, and we will do our best to answer those questions this evening. Feel free to ask a question to Dr. Taylor and or to Todd, whoever you'd like, and we'll try to get those. So we're going to go ahead and start our program, and we're going to start off with Dr. Taylor discussing a little bit more about what is GERD, and what are symptoms that patients could feel if they were suffering from GERD.
So, GERD is an acronym that stands for gastroesophageal reflux disease. It is essentially a disease in which acid from the stomach refluxes up into the esophagus, and that causes irritation of the can produce a variety of symptoms. The most common symptom that people have is something that's called heartburn. It feels like you're having a burning in your chest, kind of in and around your heart, and so that's where that term originated from. People can have pain in their upper abdomen. They may also feel some bloating or discomfort after eating. And then if they have really severe symptoms, they can have regurgitation of acid up into the top of their throat and feel like they're having kind of a frothy type sensation. And what we would call alarm symptoms, or the really severe symptoms, are when people have it so severe that it's causing irritation of their airway. So people can have a chronic cough or wake up in the mornings with a hoarse voice. It can be the source of a cause of developing bronchitis and pneumonias. It can even cause irritation of the teeth and cause breakdown in cavities. So those are kind of the variety of symptoms that patients can present with gastroesophageal reflux disease.
Thank you, Dr. Taylor. And Todd, I know you kind of suffered for many years with some of those symptoms that Dr. Taylor had mentioned. Can you tell us a little bit about your story and how long you were suffering from?
Yeah, so I've had heartburn for as long as I can remember, on and off. Even going back to my teenage years, I would take antacids, and then probably in my mid 30s, I started having some occasional acid reflux at night when I would sleep, and ended up in my late 30s getting on PPIs. I'm 52 now, so you can do the math. So I've been taking more than 10 years on PPIs. So it's progressively gotten worse as I've gotten older, um, and so I just had to really be careful about what I would eat and what time that I would eat. And for me, it had gotten to where it was mostly at night when I would sleep. But the symptoms would be, I'd wake up with just, I would actually feel the acid run up into my throat, and so uh, and it was always very uncomfortable, and I would usually get up and try to take an antacid, even if I had taken my PPI that day. If I ever forgot to take the PPI, or if I ate something that I shouldn't have, then it was just going to be a miserable night. And so I started looking for. I talked to my GI about it, and they just kept telling me to take my PPIs, and so that's the way I had managed it for a long time.
Yeah. Yeah, thank you for your story. So, Dr. Taylor, talking about managing GERD, you as a general surgeon, you're probably seeing patients at the point where they're already done everything that they can, right? So, you're not seeing them kind of at that early stages where they're just getting prescribed PPIs. But what would you normally recommend patients, you know, that are kind of trying to just manage GERD? Are there lifestyle changes that they should do? Are there food modifications? Maybe just some of those things, if you can give some recommendation.
So certainly as a first course of treatment, we generally talk to folks about diet and lifestyle modifications. And so from a diet standpoint, certainly minimizing or cutting out caffeine. Chocolate has been associated with increased reflux. Certainly patients oftentimes talk about foods that are more acidic. So citric foods, tomato-based foods can tend to cause more issues. And so avoidance of those triggers can be incredibly important. Certainly people who smoke are more at risk for developing reflux. And so really any nicotine use is an increased risk factor. So whether that be chewing tobacco, dipping, or smoking. And so we talk to folks about stopping their tobacco use. And then other lifestyle modifications. Weight plays a role. And so weight loss can be helpful in controlling reflux. And other kind of simple things we talk to folks about, making sure that posture is a very important thing. Having good posture, sitting upright, kind of keeping pressure off the stomach, certainly after eating. We also talk to patients about trying to eat at least 2 hours before they lie down for bed, at night, to allow their food to be more digested and hopefully emptied out of the stomach, so that reflux, that acid is not as present in their stomach. And then, there are certainly folks who sleep propped up in recliners or use multiple pillows. And so those are all things that can be used to help with initial treatment of GERD.
Perfect. Thank you. Gosh, I've never heard of the posture one, but that makes perfect sense. Sense. Right. So I'm trying to sit up as you're talking. So thank you for that. And let's talk a little bit about, the PPIs. I know Todd had talked about taking PPIs, and then let's talk a little bit more about moving into kind of diagnostic testing in order to determine if a person is a candidate for the TIF procedure. Now, I understand that Todd has a very interesting story about getting his diagnostic testings and whatnot before he even found you. But before we go into that, Dr. Taylor, can you tell us what is your protocol and the testing that patients would generally have to do in order to determine if they have GERD and are a candidate?
As you mentioned, as a surgeon, I typically see folks a little bit sort of more progressed along their treatment course for GERD. But if you're seeing your primary doctor, if you see a GI, typically if you describe what we would consider typical GERD symptoms, they're most likely going to place you on some form of an acid reducing medication, whether that be what's called an H2 blocker or a PPI, a proton pump inhibitor. Both of those medications work on the acid producing cells within the stomach to actually decrease the amount of acid that is produced. Now, having said that, some people have a response to their symptoms who don't necessarily have true reflux. And so if we're talking about getting to the point of needing a procedure for your reflux, we want to know a couple of things. Number one is are you having true acid reflux? And so typically we evaluate that with what's called a pH probe test. And so the way that that's typically done now is that a doctor will take and do an upper endoscopy scope, and they'll place that probe within your esophagus. And over the course of several days, it'll monitor how much acid is refluxing it, and it can give us an idea of how severe things are. Then the second part of acid reflux is that people who've had acid reflux for a long time or other potential problems can be associated with difficulty swallowing. And so if we're talking about performing a procedure that is going to decrease the amount of things that can reflux up, it's also going to potentially affect how well you swallow. And so typically we obtain a test called a manometry, an esophageal manometry, which is essentially just a pressure readout to tell us kind of how strong and how effective the esophagus functions, so that if we decide that you're a candidate for the TIF, we want to make sure that you're not going to have issues swallowing after the procedure.
Perfect. Thank you. Sorry, I was on mute.
Okay.
Typical Skype issue, right? Thank you for that, Dr. Taylor.
Yeah.
Todd, tell us about your story. I know that Dr. Taylor wasn't originally the first physician that you saw for your GERD. Kind of give us your story on what happened there.
The person that, my primary care physician was the one that had been prescribing the PPIs for me. One thing I haven't shared, my father-in-law got esophageal cancer, and he ended up passing away from other causes. But just knowing what the treatment is for esophageal cancer and learning about that, I didn't want that. And so with GERD, it's a risk factor, and so certainly put that on my radar for me. So I began researching it and paying more attention to that, and then when I turned 50, it was time for the colonoscopy, and so I went and saw the GI, and we had a talk and about, let's do the top side as well. Just make sure you do the bottom side second. So we did that, and so he showed me some results where I had signs and symptoms of GERD. It had not progressed to a condition called Barrett's esophagus or anything like that. I'd already learned about the TIF ahead of this procedure, and so I started talking to him about it, and he was not familiar with it. And I had my iPad with me, and I'm a strange patient. I pulled out the iPad and showed him the video, and so he said, "Oh, this is like the Nissen funduplication, but it's different." And so but he wasn't really familiar with the procedure itself. So he was not able to guide me. So on my own, I ended up, I spent probably more than 18 months researching, do I think this is right for me? And then I made the decision, yeah, I think this is right for me. And so I began looking at a provider that would do it. And so researched several providers and found Dr. Taylor and Dr. Melvin, and placed a call to them for a consultation appointment. Went and got that. Dr. Taylor wanted to do some diagnostics to make sure that I am a candidate. I brought all my medical records previously that I had, but esophageal manometry was one that he was interested in. And so I live 2 hours away. I'm in North Alabama, and he's in outside of Nashville. So we were able to do my diagnostic testing here locally. So I saw a different GI for that esophageal manometry, and him about it. He actually tried to talk me out of it, and so I started questioning him why, and he just said, you just need to keep taking your pills. It's there's research out there that says this and research out there that says that, but they're safe. You just need to keep taking them. And the thing that kept sticking in my mind is I have a mechanical problem, not a chemical problem. I have a sphincter muscle that's between my um, esophagus and stomach that's loose, and and I don't have a chemical problem, and um, so ended up after, and I didn't do too well on the esophageal manometry test. So Dr. Taylor was a bit concerned about my ability to swallow post the surgery.
Mm.
So he ordered a barium swallow test, and so I did the barium swallow test, and that gave him assurance that this was going to work. Um, so we went through with the procedure.
Wonderful. Thank you for sharing that. First and foremost, I'm sorry to hear about your father. And interestingly enough, April, which was 2 days away, is Esophageal Cancer Awareness Month. So we're actually doing a lot to help build awareness around esophageal cancer awareness. And you're absolutely right. GERD is a precursor, if you will, to that. So um, interesting about your story that you had gone to several different physicians, some that did know about it or some that didn't know about it, and then also some that were trying to talk you out of it. And I always love to hear the stories from the patients that kind of become their own advocate, and do their own research and find out what do they think is right for them. Because I think every patient is different. Dr. Taylor, you probably agree with me on that. And kind of rolling into, GERD treatment, what are the GERD treatment options that are out there? TIF is one of them, and it's not always going to be the perfect one for everybody. But can you discuss a little bit about different options for GERD? You can even talk about comparison of Nissen and TIF and
Yeah, so when somebody like Todd gets to the point where they're concerned about how long they've been on PPIs or their reflux is worsening and the medications are not working anymore for them effectively, then that's when we begin to start talking about the idea of what we call an anti-reflux procedure. And so the traditional anti-reflux procedure that I think most physicians are familiar with is certainly something called a Nissen fundoplication. It's where the top part of the stomach is freed from its attachments and then wrapped around the esophagus. And so the way I describe it to patients is it's creating essentially a speed bump, if you will, to slow the flow of things both in and out. From my perspective as a surgeon, I was trained and have performed the Nissen fundoplication. It is what we in surgery would consider probably the gold standard for an anti-reflux procedure because it is so effective. The problem that we have is just like in Todd's case, I don't think that he would have been a very good candidate for that procedure because his esophagus was not functioning normally. And I think probably from longstanding issues from how long he's had GERD. And so there are variations on that procedure that we have performed historically surgically, something called a toupee, which is where you kind of create just a C-shape wrap around the esophagus so it doesn't completely wrap it. But you compare that to the TIF. And so the TIF is really, as I've begun to perform this and see it, and I've had patients undergo it, from my perspective, it's much more of a anatomic similarity to what we should naturally have. So we take the tissue internally and we build that up using the scope device and the H sutures that help at the junction of the esophagus and the stomach to create that what we call internal fundoplication or gathering up of the tissue. And so it almost creates sort of a one-way valve, if you will. And so when you swallow, things aren't going past that that outside pressure, that speed bump of like the Nissen that's there, but more things are passing through the valve. And now you've taken, and that internally bunched up tissue is going to come back together, and it's not going to allow things to reflux back up. And then finally, the other common procedure is what they call sphincter augmentation, magnetic sphincter augmentation, primarily the LINX procedure. And so, you know, there are a variety of issues as to why somebody would undergo that, but it's a series of very weak magnets that are attached on a string, essentially. And so as you swallow, they can stretch out, but then they're quickly brought back together, and again, that can prevent things from refluxing up. And so the workup that a patient will undergo, the manometry, the barium swallow, those are things that are incredibly important to help make a decision about what a patient needs. And one of the things we haven't talked about yet, which is also sometimes patients have hiatal hernias, and those hiatal hernias can affect their reflux. And so that makes a difference in terms of what we would perform as well.
Perfect. I'm glad you brought that up. Can you explain what a hiatal hernia is? And I know, Todd, you had both your concomitant procedure, hiatal hernia repair, and the TIF procedure. Can you explain what a hiatal hernia is just briefly? And then we've got tons of questions that have popped up, so we'll go through those after. Yeah.
So a hiatal hernia is a hernia through the diaphragm muscle. So the diaphragm muscle, one of our primary breathing muscles, separates essentially our chest from our abdomen and the organs in between. And so the esophagus, the swallowing tube, will pass through a small opening through the diaphragm muscle. Well, that opening can get larger over the course of life, doing heavy labor or lifting activities, pregnancy, aging, weight. And so that opening can then allow for the abdomen, the abdominal contents, to push up into the chest. So we generate more pressure because of our muscles in our abdomen. And so that can cause the stomach to push up. And so studies have shown that diaphragm muscle is actually very much a part of our natural reflux barrier. And so if that's not intact, then that's when we start thinking that with surgery, we need to repair that as well.
Perfect. Thank you. I appreciate you explaining that. Okay, let's get to some questions. First things first, Suzanne is asking, what does TIF stand for?
Great. So TIF stands for transoral incisionless fundoplication. So what that means is we're going to go through the mouth, so transoral, and there are no incisions to perform the procedure. And then the fundoplication, like I said, is that kind of gathering or bunching up of the tissue at that area where the natural reflux valve should be.
Perfect. Thank you. And we have another question from Din. They're asking, are these tests, so they're probably talking about the diagnostic tests, something standard by every doctor or something we should be asking about? Because my GI doctor said she doesn't do surgeries for this, so she referred me to someone else. So what should I be asking to know if I'm a candidate for TIF?
So certainly from my perspective, I think the worst thing that I could do is make somebody's problem worse. And so that's why I think those tests are very important. The checking the pH test, the manometry test, and the barium swallow test sometimes, all of those are going to give us information about what is the appropriate, what we can do appropriately for you so that we can best control your reflux, but also manage any potential issues that have come up over time. Again, that reflux can really cause irritation and weaken the esophagus muscle. And so if you can't swallow and somebody tells you need a Nissen, you might wake up and not be able to swallow at all. And so, you know, for me, that would be something I would want to never happen. And so absolutely, I think that, you know, in my training, the way I was taught about how to work this up is you want to know what their anatomy looks like. And so if somebody's had a scope, you can tell if they maybe have a hiatal hernia and what things look like internally. Alternatively, the barium swallow can show you the pictures of their anatomy. You want to know how strong their esophagus is, and that's where the manometry comes in. And then you want to see that they have what we consider objective or measurable signs that they truly have reflux. So again, typically that's the pH probe, but sometimes there are signs like Todd had on his scope of having already sort of some changes associated with reflux.
Yeah, perfect. Thank you. We have another question. This one's for Todd. Shane's asking, Todd, what was your recovery like?
Well, I had the surgery on a Friday. Dr. Taylor told me not to work. Plan on not working for a week. I work from home. I sit in this chair every day, working from home. I worked on Monday, but it was not a work day. Because I had spent the weekend kind of lounging around, um, and I was Monday was not a good day for me from a work standpoint, but I did work pretty much the whole day. Um, but fortunately, I have a sedentary job. The diet was a bit of a that's a little bit of a challenge. So it's first 3 days was clear liquids, and then you go to liquids that are not clear. So I could have strained soups, and cream of chicken soup became my friend. Um, and that graduated to semi-solids and things all the way up to 6 weeks. And that was that was probably the most difficult part for me, because one of my primary drivers for having this surgery is I like to eat, and so that was I had never done without. For me, fasting for a cholesterol check in the morning time is that's a major deal. And so this would, going 6 weeks without having a piece of grilled chicken or a steak or something like that was going to be a big deal for me. But uh, I never really missed a beat. I had a pretty tight weight restriction. I think it was 10 or 15 pounds. And so I might have milked that a little bit around the house. To uh, so, but and I had some pain. I think the pain was my pain really didn't start till probably Monday or Tuesday, and I think the pain actually I called Dr. Taylor's office because I was saying something's not this. I shouldn't have this shoulder pain. And it was up in my shoulder, and I was concerned about it. But I was not taking my pain pills, and so I had done some reading on the internet, and that got me concerned that I had a more serious condition. And Dr. Taylor said, take your pills and let me know if that doesn't resolve it. And it resolved it. So
Well, there you go. There you go. A little 4 to 6 weeks. But where are you today? Are you able to eat the foods that you want? Are you back to your old self again?
yeah, I mean, I have no restrictions now, and you know, I, I can eat anything, drink anything. I've not had any trouble with any food so far.
Fantastic.
One
Yeah.
thing I will add, just as during that 4 to 6 week period, we Dr. Taylor and I were both concerned about my swallowing ability, and so because I didn't do well on the esophageal manometry test, and so I had some slow swallowing, and he described to me that at the time when the surgery is done, there's going to be some swelling, and but what that felt like was I would swallow, and usually the first bite I would swallow and it would go down, no problem. Second or third bite, um, it would get here, and it would feel just like some pressure in my chest,
Mhm.
and then it would just go down slowly. And so I just had to eat slower, especially during that 6 weeks. But that's completely gone away. And so,
Yeah, that makes sense. I believe, and Dr. Taylor, you can speak to this. You fixed his hernia as well as creating a new valve for him. So, compared to what you were used to, having everything come down pretty easy, to your point, you got to take things a little bit slower, right, Dr. Taylor?
Oh yeah, absolutely. I mean, I think if a patient undergoes what Todd underwent, which was what we would call abbreviated a CTIF, which means concomitant hiatal hernia repair with the TIF, or even just a pure TIF, everybody's going to have some sort of version of some difficulty swallowing early on. After we do the procedure, we know that things are going to be a little swollen, and certainly, I mean, I think Todd's kind of time frame there, that third, fourth day after surgery, is typically when it's at its most severe, and so that's a very common time frame for me to begin to hear from patients about some feedback of issues they may be having. And then that's why I think the advancement of the diet being kind of very slow and methodical is also very important. Is that it gives time for that swelling to improve, for things to begin to heal, to not overdo or overstretch where we've created that valve or repaired that hiatal hernia, because we want, quite frankly, some good scar on that area, so this doesn't happen again, hopefully. And so, sticking to the diet is certainly very important. It is challenging for folks. Todd is not alone in that. We all like to eat, and so it is. What I tell folks is it's a limited amount of time to get to the end goal of having relief and some normalcy for yourself.
Yeah, that's perfectly said, Dr. Taylor. So we've got a couple more questions. We've got Jamie, and she's asking, what can cause conflict? Ooh, where did just jumped away? Sorry. What can cause conflicting test results? Example: a CT scan shows a hiatal hernia, but barium swallows says no hernia.
Well, one of the things you have to think about is the way you're positioned when you're having that test. So you may have what's called a sliding hiatal hernia, which is a very early hiatal hernia. And so when you're having a CT scan, you're lying flat. And so all the pressure from your belly and everything is then going to be pushing things up. So you may actually see that on the CT scan. But typically when you're doing a barium swallow, you're actually sitting upright. And so if you have a small hiatal hernia, it may not show up on the barium swallow. And so that's why having somebody look over those images, maybe potentially having a third study such as a upper scope where they can go in and actually potentially physically see the hernia is important.
Perfect. You. Another question we've got from Andrea. She's asking, from what I've read, on average, the duration of a TIF is around 10 years. Assuming this is the average and I'm in my early 40s, can I realistically have the TIF redone multiple times throughout my life?
That's a great question. So, what I would say is quite frankly, I tell folks for any anti-reflux procedure, really most of the literature would say 10 years is about the ideal number that we would want before somebody potentially starts to think about or starts having symptoms and maybe needs something else done. I think the great thing about the TIF, because it's transoral, we're not having to go back in and redo the wrap externally with surgery where scar tissue and things like that can be. And so I think the TIF is well suited to help someone who maybe is younger and earlier in life, who, over 20, 30 years may need something else done again. And so we can go back in and, obviously they'll undergo testing again to make sure everything is as it should be. But I think the TIF is well suited to be able to redo or help sort of snug up things that have maybe loosened over time.
Perfect. Thank you. We've got some very educated patients that are asking
Yeah.
questions. So I'm not surprised on these questions, but I will read them to you. So this one I've read, this is from Mitch. I've read the 1 year reoccurrence rate for hiatal hernia is about 10%. Is this because the stitches aren't flexible, as in they don't stretch with motion?
That's a great question. The truth is we probably don't fully know all the reasons why hiatal hernias recur, but the biggest issue you have to think about is that number one, I'm going to use my hand here to kind of mimic the diaphragm, the opening of the diaphragm, and then the swallowing tube. Okay, so every time you swallow, that muscle kind of squeezes and moves. So there's constant movement there. And then certainly every time you breathe, your diaphragm muscle is also moving. So that constant movement and motion can affect it. When you swallow also, you know, let's say you take a big bite of something and you do like me and you don't chew it very well and you just choke it down, well, that can stretch that opening up a little bit. Certainly as we age and our weight gets worse, or we're staying, you know, active and physically fit, all of those can be reasons why there's pressure. And so as a general surgeon, I treat all types of hernias. And one of the things I tell folks about hiatal hernias is we can't completely close the hole. The ideal situation to fix a hernia would be if I totally close the hole. That's going to prevent any hole from coming back. But since you have to have an opening for your swallowing tube to go through, every time there's pressure or movement, there's going to be stress and strain put back on that hole. And so, yes, there is a higher chance of a hiatal hernia coming back.
Thank you. He's got a second part to his
Sure.
question. Is there a way to induce scar tissue just at the crura, like with electro or mechanical stimulation, so as to ensure strength? Similar to the concept of the scar tissue developing for strength with the TIF staples. And he says, thank you. You guys are great.
Well, thank you. I like his thought. To my knowledge, there's not been any data that has shown that to be more effective at creating scar tissue than the scar tissue that's sort of naturally created when we do surgery. And so there's even, you know, certainly in situations sometimes if there's a very large hernia, we may use we'll call a biologic material that can help reinforce or strengthen that area early on. And so the data that's been studied shows that it does help early prevent the chances of a hiatal hernia coming back. But over time, those if you had mesh or not mesh, those numbers kind of come together, and your chances of a hernia coming back are similar with time.
Perfect. Thank you. One last question, and we'll kind of roll to the ending of this talk. But Tyler's asking, can I get a TIF if I have Barrett's esophagus?
So I think the first question would be sort of what stage of Barrett's esophagus and the findings that are there. But certainly what I would say is that is not a absolute contraindication or a reason that you cannot have a TIF. And anti-reflux surgeries have been shown to help prevent the progression of Barrett's, and TIF would be very similar into that. And so Barrett's alone is not a reason that you can't have a TIF.
Right, thank you. We'll get to one last question. We got a lot of questions, guys, so it's good. I just had an upper GI. This is from James. I just had an upper GI, and in the recovery room, he asked his gastroenterologist if he would be a candidate for the TIF. I mean, the doctor said no, but none of the meds have helped him in the past 5 years. So he's wondering, are there doctors who just aren't being open to this procedure? And this is more to you, Dr. Taylor. Have you seen, or even maybe you, Todd, because you ran into this a couple of times, have you seen any professional resistance to, you know, doing the TIF procedure?
Todd, you go ahead.
I had one GI that was not familiar with the TIF, but so he couldn't advise me. And I had another one that just said he would not recommend it. But in the discussions, I'd done a lot of reading ahead of that, and I started quoting some of the statistics that I had read, and I asked him where his data was from, and he just didn't give me anything that comforted me. So I follow data.
Yeah, that's great. Yeah, Dr.
So
Taylor.
my answer to that would be certainly there may be physicians who are not educated about what the TIF procedure is. So there certainly may be that component of it. But I think in fairness, most GI doctors are familiar with the surgical fundoplication, and that is not without its issues. And it's why I have transitioned by and large the majority of my practice to the TIF, because I have seen less of those issues that patients have after surgery with a Nissen with the TIF. So difficulty swallowing, sometimes you can't burp or belch. And so there are lots of things that can go into that. And so doctors may have seen other patients who have undergone those types of procedures. And I think in fairness, they would probably want to warn their patients against something like that. So they may not be familiar with the TIF. They know what a surgical fundoplication is, and they're like, listen, you're not that bad off. You don't want to undergo that just yet. And so certainly there may be some component of educating them that, well, there's this other procedure and things like that, but also doing like Todd did, which is doing your own research. And I think certainly evaluating that and the resources that are provided through girdhelp.com that Endogastric Solutions has, I think is a really great resource for that.
Yeah, that's perfectly said. And thank you for answering that. That's a tricky one, right? So, I always say an educated patient is always the best patient, right? It's do your homework, kind of be your own patient advocate. And if you're not 100% comfortable with what they're telling you, doesn't mean it's wrong or right. It's just what you feel is right for you. And the physicians will say that too, right, to the patient. Like everyone's different, and not every procedures or treatment option is the right treatment option. So with that said, as we conclude this TIF talk, I'll start with you, Todd. What are your last words of advice that you would give to patients that are watching tonight?
I think doing your own research. I don't think any individual should put their total health care totally in the hands of a physician. I think you want to use physicians and you want to take the advice of physicians, but ultimately your health is your own health, and so you have to own that. And so that's my advice. And I have, I make that comment with all the respect in the world for Dr. Taylor.
Yeah, perfect. Dr. Taylor, how about you? Any words of advice for anyone watching tonight?
Well, I would certainly echo what Todd just said, which is as a patient, certainly do your homework. I think there's lots of stuff out there that can help patients learn and understand about the benefits of the TIF, about maybe why being on PPIs and H2 blockers long-term is not good. But also you want to make sure that when you sit down with your physician, you understand, why am I a candidate? What do my results show? What can I reasonably expect? I think that that knowledge can be empowering for patients.
Perfectly said. Thank you. Well, thank you both so much for joining us this evening. I know everybody that was on tonight, there was quite a few people, really enjoyed it, and thanked you both for being on here and giving, obviously your honest feedback, Todd, and then Dr. Taylor, your expertise. So we can't thank you enough. If you're in, is it Smyrna? Is that how you say it? Smyrna?
Smyrna.
Smyrna, I'll get it. Smyrna, Tennessee. You can see Dr. Taylor. And if you're a little bit further away, like Todd was, you still can. But if you're not, you can go to girdhelp.com, as Dr. Taylor had mentioned. There is a lot of information on there. In addition to that, you can find a physician in your area by putting in your state and or zip code, and you'll be able to find a physician, a TIF trained physician, if you will, in your area. So on that note, we can't thank everybody enough for joining us. Thank you very much for your questions. Dr. Taylor and Todd, thank you so much for joining us this evening. And you guys can catch us next Tuesday, for our next TIF Talk. So thank you, everybody, and have a great night.
Thank you.